Dr. Mahima Kaushal. Dr. Mahima Kaushal is going to talk about triple drug super selective intraarterial chemotherapy for retinoblastoma in Asian Indian population.
Childhood cancer chemotherapy. A trio no parent ever wants to hear and no doctor is glad to face. And what's more, the standard IV chemotherapy doesn't just attack the tumor. It travels the whole body, leaving behind a trail of toxic side effects. This is where super selective intraarterial chemotherapy has changed the game. So with this background, let's explore triple drug super selective intraarterial chemotherapy for retinoblastoma in the Asian Indian population. The journey of intraarterial chemotherapy spans decades. Here's a quick timeline. In 1958, Rees was the first to use it with triethylmelamine through the internal carotid artery. It was abandoned due to systemic toxicity. Then in 1968, Kiribuchi reported tumor regression via ophthalmic artery infusion. This was followed by melphalan introduction into the intraarterial chemotherapy regimen with a balloon catheter in the 1980s. Then in 2006, Gobin and Abramson refined the technique of ophthalmic artery catheterization and standardized the term super selective IAC as we know it today. Here are the various types of IAC terminologies depending on their methods of administration and indications. The procedure starts by marking the correct eye with large arrows and ipsilateral thigh whose femoral artery is to be accessed. A 5 French catheter is advanced through the femoral artery, then the aorta to reach the ophthalmic artery ostium as seen. Brain angiogram and a choroidal flush is seen to confirm the location. This is followed by administration of the chemotherapeutic drugs diluted in 30 ml of saline and manually infused over 30 minutes in a pulsatile fashion. The therapeutic drugs themselves have evolved over time from a single agent melphalan to triple agent melphalan to topotecan carboplatin added by Abramson as we know it today. So we conducted a retrospective consecutive interventional case series analyzing 157 cases in which 163 eyes underwent a total of 414 IAC infusions. At a mean follow-up of 5 years, with a range of 1.5 to 7 years, we're proud to report 100% life salvage. From the following figures, we can deduce that unilateral eyes are more often treated with primary IAC, while bilateral cases usually had IAC as a secondary measure. On ICRB group-wise analysis, IAC was mainly chosen as the first line for group D and E cases, while secondary was used in historically D and E grouped cases and in almost 1/3 of the cases grouped and treated elsewhere before presenting to our center. The main indications that arose for secondary IAC in our study was for tumor recurrence in 50% and refractory or residual tumor in the other half. In both the primary and secondary groups, significant eye and vision salvage numbers were achieved. Among the eyes that needed enucleation, most of them were due to tumors not responding to treatment, while the remaining 10 eyes, which were 20%, were enucleated due to recurrence. So a 5-year enucleation-free period could be achieved in overall of 72.6% cases as seen from this Kaplan-Meier graph. Here's a glimpse of outcomes of how our patients fared with IAC. A case of 8-month-old child with group B retinoblastoma showing complete regression in the form of calcification after IAC completion. Group D retinoblastoma on its way to a beautiful regression in a 3-year-old child. Group E clearing up after primary IAC, making the disc visible. And here's how some of the secondarily treated eyes fared. The strength of our study is that we were able to achieve excellent regression in lesser number of cycles of IAC with better globe salvage at a longer duration of follow-up. This was seen even in advanced cases, especially group D and E, representing a very real-world cohort and not cherry-picked cases. Our study builds on the foundation laid by a prior review where the authors highlighted the importance of careful patient selection and the need for a multidisciplinary team. But we must remember the cost plays a large role, as IAC costs 10 times more than IVC. Triple drug super selective ophthalmic artery for retinoblastoma has shown excellent efficacy. There's targeted delivery with minimal side effects. but high cost makes IV chemotherapy still more accessible in many of the developing countries. Thank you.
A very good presentation, but as you said, the availability of IAC and the cost limit its use. So going forward, as you are a very young ophthalmologist, going forward, how would you like to incorporate this to reach the maximum number of audience or the deserving child?
It can be reserved for cases where the tumor is not responding to conventional IV chemotherapy.
So you would like to go for conventional chemo first, and then if it's not responding, then go for IAC?
Yes, because secondary has also given very beautiful results, and live salvage and globe salvage is commendable over there.
Okay, thank you.
What about the systemic microstatices which could take place?
If there is pre-existing systemic micrometastasis which can be radiologically evident, then we cannot go for IAC because it will only give local tumor control. It does not protect from systemic metastasis.
So
In that regard, IV chemo is better.
all right.